Well, I'm not going to say thank you very much until the lecture's over, but I'm going to say welcome to everyone. Again, you'll notice that this is not a typical DOTS decorative art lecture, but for typical dotty ladies like me, as we get older, so do our health issues become so much more important. So it's really nice to know that there is something that science has developed to check on things like our DNA and whether we're getting the right food and, more importantly, the right medicines. Karen Denton, whom you're going to hear in a few minutes, is a healthcare professional, and she is going to tell you all about it. Here she is. Over to you, Karen.
Thank you, Sue, and thank you everyone for being here. I'm always very pleased when Sue contacts me and says, would I like to do a talk for this group? It is a really special group, so thank you. As you said, we're going to be talking about why is it so different for me? Are we all that unique? Let's have a look. In other words, why doesn't this or that medication maybe work for me? And the answer is, it's all in our genes. But let's unpack that a little bit. Let's look a little bit further. As we do this, I want you to remember that Claudette and I are from Retina South Africa, and we provide a whole host of different services to patients with various retinal diseases throughout the country, and in fact, especially since lockdown worldwide. We are a very small team in the country, but we are very proud to be particularly effective, and this includes our volunteer staff as well. Claudette and I work very closely together, and here you can see us at a conference where we presented papers. I think it was in Cape Town, and we've just come back from another one. I'm also part of the Low Vision Center of Learning, where we do quite a lot of lectures on the eye as well, and we do weekly webinars as well. And today, we're going to be talking about two very important topics. They've got very big names. So let's start with pharmacogenomics. And at the end of this, you'll know exactly what we're talking about, and nutrigenomics. So let's start then with pharmacogenomics. This is a pretty big word, and it sounds very impressive. What does it actually mean? It means it is the science of personalizing your drug treatments, your medications, the way you take a tablet, a capsule, an injection, anything like that. And the way you take it will be different based on your individual DNA profile. That's huge. We know that at the moment, if we give a tablet to anybody, for one person, it'll be fully effective. For another person, it will be only half as effective, and they actually need a double dose. But do they even know this? For another person, they'll overreact to it, and they, in fact, only needed half that dose. And for another person, it might have no action whatsoever. It will wasting their time taking it. So if we look at a group of people with exactly the same disease profile, if they are given the same drug, the same prescription, and the same dose, we know that a percentage of them, the drug will work. In a percentage of them, it won't work. And in some of them, it might even be toxic and might even be hazardous, not only to their health, but to their life. Because of this varying profile with everybody, has become the topic of multiple medical journals throughout the world. And you can pick up hundreds of these everywhere. The role of pharmacogenomics in the way medicine is developing today, as we talk, as you and I talk. In fact, it's not only the medical journals, it's even been picked up in the lay press. Things like Time Magazine, Newsweek, etc., have published multiple articles on exactly this topic. So in the future then, our prescriptions are going to look something like this. As always, we'll have your name, your address, but then we will also add your DNA profile. That is going to be of paramount importance to every single prescription that you get, everything that you take. If we look at a group of people, superficially, yes, we're all the same. We all have a nose, 2 eyes, a mouth, limbs. We look pretty similar. But are we all the same? Do these people walking down the street and these people have anything at all in common? If so, what do they have in common? So if we look at them, you'll find that we share a staggering 99.97% of our DNA. Yours, mine, everyone online today. We all share 99.97% of our DNA is identical. So whether it's you or these people in Kenya or the people walking down the road in London or New York, wherever that is, exactly the same. Only 0.03% is different. But that 0.03 determines your hair color, the texture of your hair, the waviness of your hair, your skin color and texture, your eye color, size, shape. In other words, everything that makes you who you are, everything that makes you the unique person who is here today. So, based on this then, we can look at DNA and we can find that people, based on their DNA, can be tall and slim. They can be rotund. They can be very active and sporty. They can be autistic, as some people are. In other words, there's a whole lot in the genes in that 0.03% that makes a huge difference. But wow, what a difference that tiny percentage actually is. So if we are so similar, if we share 99.9% of our DNA, why then do some of us eat anything we like? And we all know people like that, and they remain slim and trim. And other people eat one donut and gain a whole kilo. Why do some people have only one tot and they are rolling drunk, and others can have an entire bottle or two and they're fine? Some people hardly exercise and remain fit, but others exercise and try so hard and they never seem to get quite there. We can carry on with this, sitting in the sun, etc. Have an espresso at bedtime. You get the idea. This is why is it all so different? And then, of course, this brings us to the question, why do medicines that work for you not work for me? Why do medicines that seem to work for everybody else be ineffective for me, or the other way around? We know that variability is a part of life, and just as no two people are alike and no individuals react alike and behave alike under abnormal conditions that we know as disease, this was said by William Osler 120 years ago already. They already noticed then, 120 years ago, that the way we reacted to disease and to medication differed with person to person. And just to summarize once again, if you take exactly the same disease with the same medication, with some people, it will be completely toxic and no benefit to the person whatsoever. With others, there will be some benefit, it will treat the disease, but the side effects are so bad that it's intolerable. They actually can't take it. With some, there is no toxicity, but also no benefit. It doesn't do anything in that person's life whatsoever. And in a few, you get benefit, and no toxicity. And note that I said that out of this group of people, the number who are actually benefiting is remarkably low. The numbers are few. So, what do we do about the situation? Because we now know that it is all in that 0.03% of the difference in our genes. And just as our bodies handle coffee, alcohol, food, exercise, everything differently, we, each and every one of us, metabolizes our medications completely differently. So even aspirins, paracetamol, antibiotics, cholesterol-lowering drugs, vitamins, diabetes medications, all of these things are completely individual to you. They are different. And no medication on the planet today is exempt from this, because all of us react completely differently to every single one of them. And this is why you shouldn't actually be taking your friend or your husband or your neighbor's medication. If it works for them, fantastic. It might not work for you. So we will look further into the medical side of things. But in the meantime, we also spoke about nutritional genomics or nutrigenomics, which is broadly defined as the relationship between nutrients, diet, and our genes. So, is it possible then that a tomato that's good for somebody else might not be that good for me? Is an avocado that works wonders for some people might not be that good for my life? And I think a very clear example of this is the large number of people who are allergic to different things. That's their body's already telling them, this doesn't work for you, like nuts and different products that people simply cannot take. This has become so visible in the world today that there are stores in both the United Kingdom and the United States where you can, in fact, shop with your DNA. And this is very, very interesting. For example, in the UK, stores like Waitrose and John Lewis have now introduced DNA shopping in many of their stores. And as it rolls out, I'm sure it'll be reaching more and more and more of them. They're letting you shop based on your own individual DNA profile. And all you have to do is test at the store. So you go in, you do a little test, and it's just a little mouth swab. And you only ever do this once. Obviously, your DNA is not going to change next week. It's the same this week and next week as well. The results are relayed to your smartphone, but if you don't have a smartphone, I'm not sure who doesn't have one because everyone seems to have one, you can get a little band that you can put onto your wrist, and the result is relayed to the band. So either the band or the smartphone. You then go around the store and you shop according to that. And as I said, it's a quick, on-the-spot, one-time little swab. It takes just a few moments to do. And after about 20 minutes or so, they will give you your personalized DNA report that will appear on your cell phone. You can then use that to scan. You use your phone to scan the barcode of any product on that shelf. And your DNA suitability for that product, your individual DNA suitability will be assessed. If your little band flashes green, or if on your phone you get little green go light, it means that that is fine for you. This product is okay for you. It'll flash red if this is not a product that you should be taking, and it will then recommend an alternative for you that will flash green for you. So in this way, you can go through any product that has a barcode and see if it is okay specifically for you. And this is just to recap once again of how it works. You have the swab, the genetic test comes up, and then you use your band or your phone to go around and do your shopping. Now we've gone that far with foodstuffs, and it makes sense that obviously the medical profession has to start prescribing medication based on our DNA profile. And because this is so essential, I think it needs to be brought forward very, very rapidly, and luckily it is being. And very few already do so, but it is beginning. It really is beginning. And in future, our prescriptions, as I said earlier, will come, and the medication that is available to you will have your DNA profile on it, and it will be on your prescription as well. So the future is not only approaching, it's virtually here, because pharmacogenomics is an absolutely critical area for improving drug therapy and the way we prescribe today, tomorrow, and in the very near future, and forever and ever. This has to be. This relatively new science unfortunately challenges the widely held view amongst many medical practitioners and pharmacists that drugs are just the same for everyone. We know now, and research has shown, because these things are never allowed to be anecdotal, they have to have research to back them up, and the research is being published regularly, that the drugs don't have the same effect on everyone at all. Now we know that there are more than 100 million DNA variations have already been identified for all of us, and thousands have been associated with very specific diseases. Thousands have also been associated with very specific drugs. And we now need to associate those factors with your DNA profile as well, so that we have drugs that labels that include the full pharmacogenomic info. And this will be based on associations found between your genes and how you will react to a certain drug. So it becomes a lot safer. And a lot of studies have already shown in the last 3, 4, 5 years are beginning to show more and more that medications are actually completely ineffective in 40% of patients with asthma, depression, or diabetes. Now, this is staggering. 40% of people are taking these products, and it is not working for them. This has got nothing to do with the quality of the drug. It's got nothing to do with the quality of the physician that you're seeing. It has only to do with the fact that we are all so completely genetically unique. We are definitely not the same. And this is just a little chart of some of the things that go wrong in diabetes. Now, just look at all these genes, look at all these things that can go wrong. And you just need 1 or 2 of these to express to have diabetes. So how can you possibly have somebody with a UGT gene receiving the same treatment as somebody with a UCP2 gene? It's not going to work for one or the other of them. It'll work on this side, not on that side, this side. And there are just too many variations. Things have to be honed down so that what you take for your problem is specific to you, your disease, your profile, everything. If we even look at anti-VEGF therapy that we use in the eye, tremendously and wonderful, wonderful products, it was found quite a few years ago that there were people who had certain genes that required double dosing. They had to have extra of this to be effective at all? So that made us start thinking, what do we do? The research continued, and they then eventually found just a single gene that found that if that gene expressed, that people did not react. Unfortunately, at the moment, patients' reactions to anti-VEGF therapy is currently unpredictable. So the response, we don't know. And people are also concerned that they can't predict who may and may not be affected by certain side effects, by certain of these drugs, how much they need. Do they need a double dose? Do they need a half dose? What do we do? So our only options at the moment are, if you don't respond after about 3 months, you need to switch to a second choice. Now, these are expensive, and I must say that if you are having problems or hear of anyone who has problems with their medical aids, in Retina South Africa, we've teamed up with a very powerful medical team who are very effective at getting the medications passed by the various medical aids for this. So, genes then are a part of our entire lives. They're a part of our existence. They're part of absolutely everything that we do. And because they're so much part of our food and everything, they really should be part of our medication as well. Now, one of the things that seems to be genetically based as well is a term that we call tachyphylaxis. And this is just a medical term, and I'm including it here just to warn you, that some people will take a certain product for months, years, and suddenly it stops working for them. It can occur after just one dose, after a week or two, or even after a few years. But tachyphylaxis can occur. If it does occur, you need to just stop that medication. There's no use taking something that's simply not working, or switch to a similar drug in the same category. For example, in the eye, we do have the 3 products. So if one doesn't work for you, we need to switch you to one of the other 2. And if they stop working, we switch to the others. In other words, we need genetic testing is the ideal before we start prescribing. And that technology basically is here already. And even the economics, financially based data suggests that based on pharmacogenomic outcomes, we can eliminate costs associated with morbidity, that's things like side effects, etc., ineffectiveness, reactions, and hospitalizations. And there are more and more of these studies being published right at the moment. In fact, one of the first was done on a blood thinner called warfarin. And they looked at a 3,600 subject study of people who were hospitalized. And they found that they could reduce hospitalizations by 30%. By 30%, if we simply knew that person's genetic profile and how they would react according to their genes, according to the blood thinner warfarin. So a 30% saving in hospitalization, as you know, is huge because hospitalization is phenomenally expensive, tens and tens of thousands of rand. Now, even 7 years ago, a doctor in South Africa had a look at precision medicine in our own country. And he found that the way we prescribe medication in this country at the moment, and we give a patient treatment A, it'll only be effective in around 20% of the target population. And 80% of that medication in South Africa is being wasted. And he then said that if we knew the genetic profile, if we had a more tailored approach, we could give treatment A, B, C, and D specific to that person's DNA. Now, everybody says the DNA tests are so expensive, but look how much it's saving in medication. It's saving 80% that's going to waste. It is going nowhere, simply being flushed down the toilet. In a more recent study, they did, the Canadian Medical Association did a cost saving, and they found that in a patient year, if they knew the genetic profile, they could save the average per patient of almost $4,000 per patient of people seeing primary care providers, that is GPs and that, over 1,300 in psychiatric care, and over $2,000 in people seeing an obstetrician or gynecologist. That is saving per patient per year by simply doing that once-off genetic test and knowing what would be most suitable for them. We now know that there are almost 100,000 genetic tests available, and yes, they are available in Johannesburg, South Africa, Cape Town as well. And about 10 new tests are being introduced every single day as we speak. And even at the moment, the people who've had this test get their prescription looking like this. So they get the medication, and on the left-hand side, for example, if you look at abacavir that is used for HIV, there is no increased risk. If you look at certain of the anti-cholesterol drugs, no additional benefit is detected. People who might have an adverse reaction to statin, such as severe muscle pain, high risk of adverse reaction to the one that this person might be taking. Aspirin, normal effectiveness, and Plavix, it's also a heart medication, normal effectiveness. And in this person, warfarin, this person would need a higher dose to get the same effect as the average other person. And as I said, this is available in South Africa today, and I know quite a few people who have prescriptions that look like this. The future then means that a pharmacogenomic test could help to avoid medication adverse events and to stop us taking things that just don't work for us, that are just being flushed down the toilet for no good reason. But the adverse events and collapsing and having a severe reaction is even more serious. It would also support physicians in working out the more appropriate and most appropriate treatment with the most suitable medication for each and every complaint that is specific for you, just for you. And this will present yet another element which will gradually bring medicine from a reactive discipline, which we do now, we wait until you have something and try it out, to a preventive discipline. So making sure that this kind of thing doesn't happen. Besides improving how drugs are used, genome research will also lead to the development of more effective, better drugs, things that are honed to be able to work more effectively, to hone in on certain areas, and drugs that will prevent the risk of side effects. And we all know that even aspirin, everything we take, does have a risk of side effects. If we look into the eye then, where gene therapy is going, there are subretinal gene therapies based on genetic profiles as well. that can increase the action of the anti-VEGF that I spoke about earlier. So you give this injection, you do it twice, and then only one anti-VEGF medication after that, and that is it. You never need another injection into the eye ever again. So you just have the two little loading doses of the AVA 101 and then one anti-VEGF medication. If you need one, maybe in a year, 5 years, 10 years, you could have it again if needed. And that trial is carrying on as we speak. They put the DNA inside a very, very harmless and very useful little virus called the adeno or adeno-associated virus. It is a tiny amount, 100 microliters is injected under the retina, tiny. And it was found that after a year, patients actually gained 9 to 12 letters on the eye chart. So not only did it prevent things getting worse, it actually helped things get somewhat better. And this is just a pictorial of the adenovirus, which is commonly used to deliver all kinds of genes and genetically modified things to our bodies. It is a wonderful little virus that does a lot of good. There's another one called RGX-314. This is a single injection as well, also delivered with the adenovirus. And in this, the RNA is delivered to the nucleus of the cell, and it will find the missing proteins that aren't there and get that right. And guess what? It only has to do that once, and that is fixed for life as well. So the future, it is not distant. In fact, as I've said, it is basically here in its infancy at the moment. We're seeing the dawn of a new age in medicine right now in the 2022. And we know that new, smarter, more specific drugs designed just for you are readily becoming available day by day, more and more. And new delivery systems are becoming available in little DNA nanoparticles. In other words, 20th century medicine that we all grew up with is now history. It's gone. Thank you.
Wow, Corinne, that was absolutely brilliant.
But I was just going to say that really was interesting, but I actually think it was more than interesting. It could actually be considered a lifesaver. I know that's a bit extreme, but it could be from the way you made it sound. And by having our own personal DNA details at hand, on our phone or around our wrist, we have a pre-warning, I suppose, of the possible problems, and then we can avoid them. So thank you, Corinne, for telling us about it. I hope that some of us will do something about it. And
one of our biggest problems is very often, Sue, thank you for saying that. One of our biggest problems is that people often phone us and they say, but so-and-so has taken this and this, but my doctor's given me something different. It's because you are different. You cannot expect to take the same as your neighbor, your cousin, someone down the road, someone you bumped into in a supermarket queue. It is just different.
What would be wonderful is, do you have a list of certain laboratories that actually do these DNA tests and that you could let us have a list of?
I don't, but I do know that in each city, I know that in Johannesburg there are 4 or 5. I know there's one in the Thrupp Center. There's one in Parktown North. I'm not sure where the others are. And I did notice one day online that one of the big national laboratories were advertising DNA testing, but a couple of people have phoned them, and when they've called them, they've said they don't know what they're talking about. So they were advertising it online. I'm not sure if they still are.
Well, if you happen to find out who's doing what, that would be very useful, and I can let our group know so that they don't have to do all this research, and it might be useful for you to have the list as well.
Yes,
so that would really be lovely. But you have made a very scientific thing, most understandable and easy to comprehend. So thank you. Thank you so much for your talk.
Thank you.
I would just like to add something, and this is from personal experience. My husband had a tooth abscess, and he went to his dentist, who gave him an antibiotic and ibuprofen. And 3 days later, some people running past my house rang the bell. We have a palisade fence, and said, "Do you know there's a man lying in your garden?" And my husband had actually collapsed from the ibuprofen, and of course, we had to take him to hospital in an ambulance, and the paramedics came, etc. And when we got to the emergency room, the very nice young doctor said, "What is he on?" And I told him, and he said, "Nobody over the age of 70 should take ibuprofen. It makes them confused, it makes them unsteady, and it's a very bad, I know it's an analgesic, and I think, Corin, it's probably also an anti-inflammatory."
It is.
He had a severe reaction to it. And when I spoke to the dentist about it the following time I saw him, he didn't know what I was talking about. So
you can buy ibuprofen across the counter. And one of the ladies recently told me very proudly that she managed to get, I think, the ibuprofen for 30 Rand.
Well, that's when something that can have such a detrimental effect on your health to cause you actually to collapse. So just be careful. And if you're not sure about something, please speak to your GP. I know they don't do house calls anymore, but usually you can get hold of them on at least by email. So I'd like to ask anybody who would like to ask a question. I can't see anything on the chat. Let's go and have a look. Nope.
I think we've stunned everyone with science.
Yeah, I think, it's new science, as Karen said, but it's certainly coming. And we know if anybody's got age-related macular degeneration is on the call, we know that that's probably going to be one of the areas where this DNA profiling really comes to the fore, because we know that these drugs are very expensive, and sometimes the side effects are quite extreme. And certainly some of those DNA tests are available, if not in this country, then certainly facilitated with overseas laboratories. So I don't see any, but then of course I've got very bad vision, so I don't see anybody with a hand up. Corin, do you?
No, and no one in the chat. So Sue, over to you then. Do you want to close?
Yes, I don't want to ask a question. I just want to say that the fact that there aren't so many questions must mean you've covered it all. So thank you so much for doing that. We do appreciate it. And we'll speak again another time. Bless you and thank you.